Hello, my name is Dr. Joseph Mikhael, and I have the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation. We had really an extraordinary ASH this year. I did a separate video where you can get the highlights of all of the major areas relevant to multiple myeloma, but I wanted to take a few minutes to talk to you about health disparities in multiple myeloma. It was really quite remarkable at ASH this year that we had over 20 abstracts in the field of health disparities in multiple myeloma alone. In fact, many others that included myeloma, but really about 20 of them that focused exclusively in multiple myeloma. And they covered multiple areas within the disease. But really, I would put them into two major categories. We have the sort of the diagnosis category and the therapy category. What I mean by that is different studies that have helped us understand the great problem of these disparities. And then thankfully also some studies looking at ways to find the solution. So what did we see in the diagnosis? Well, we saw in the PROMISE study, for example, that African Americans, as we know, are at great risk of multiple myeloma, that their risk of developing the pre-myeloma condition of MGUS is at least twice that of Caucasians. It appears to be about 10% of people over the age of 40 or 50 will indeed have evidence of an MGUS, especially with more sensitive techniques that we can use. That number may even be higher. So we know that it's common. We also saw on the diagnosis side, if you will, that there was unfortunately further associations between reduced survival in multiple myeloma and socioeconomic status, which we know adversely affects particularly minority populations, including the African American population. We also saw on the diagnosis side, access to therapies was a problem. I often talk about access to triplets, transplants, and trials, those three big T's, being a problem within the African American community in myeloma, that these patients don't have as much access to these three critical things that have changed the way we treat multiple myeloma. And many studies emphasize that point, in particular on the clinical trials front. An excellent study looking back at the pivotal studies, the pivotal clinical trials that have led to drug development and drug approval that indeed have demonstrated a rather poor participation in numbers and representation of African Americans, which really makes us ask the question of why is this and why do we let this continue, and we have to find solutions, of course, to overcome that. There was an interesting paper even from Arkansas showing to us that access to CAR T-cell therapy, so not just triplets, transplants, and trials, but maybe indeed a fourth T in CAR T-cell therapy, unfortunately does not have appropriate representation from the African American community. There are many other abstracts, of course, looking at some of the challenges that are faced, but there were, on the positive side, indeed some abstracts that looked at potential solutions of greater inclusivity, for example, in the risk stratification. Where using a new model may be more inclusive, as we know that unfortunately many African American patients don't have access to all the testing, which includes cytogenetic risk testing, that there are other ways to determine risk stratification, but also to look at a potential solution within clinical trials of finding novel sites and places where these trials can be done, as opposed to just necessarily the traditional places where we have done clinical trials. Furthermore, from our friends in Indianapolis, they've developed a fantastic program, the DRIVE program, where they suggest that every clinical trial should have a diversity officer, that there should be clear ranking based on diversity. The I stands for every individual must be involved in this process. V, there must be verification as the trial is conducted that this happens, and that their E should be enhanced training for all those of us who are involved in clinical trials to ensure that we have the cultural competence that is necessary to include patients in clinical trials, and indeed to be as inclusive as possible as we care for patients with multiple myeloma. This is a very important topic to the IMF. I encourage you to go to myeloma.org and look into our MPower project, capital M-Power, which is designed to empower patients and their communities to change the course of myeloma. The current course of myeloma, the current disparities are unacceptable. And we want to educate people, raise awareness about early and accurate diagnosis and the need of appropriate therapy in all patients, so that all patients can benefit from these great therapies that we hear about at meetings like the ASH annual meeting. So I trust this is helpful to you to highlight some of these key areas as we seek in every way possible to care for every myeloma patient. Thank you very much.